This presentation is to introduce one Cochrane review payment methods for healthcare providers working in outpatient healthcare settings. My presentation includes the following part. Firstly, I will introduce background why we choose this topic. As we know, health providers is a crucial determinant of healthcare system performance. So it's very crucial to guide the behavior of the individual providers to achieve the better performance of whole health system. One most frequently used tools to change the behavior of health providers is to change the payment method targeting them by the purchaser or the insurer. There are more and more evidences published to evaluate the interventions regarding the payment method. We choose outpatient healthcare settings is because it's a very crucial part in the whole healthcare delivery system. Even different countries have different health system delivery design. Usually the outpatient settings provide the first kind services to the patient, and it has a role of gatekeeping, so its performance is crucial to the health standards of the population and also the cost level of the whole health system. And this review is also one part of the complete evidence on demand-side payment method conducted by the Cochrane. There we targeted the payment for individual health workers. There are two Cochrane review targeting on facility level and hospitals. Here are five major payment methods targeting individual health workers, including salary, fee-for-service, capitation, pay-for-performance, and blended payment. The assumption why the payment method can change the behavior of the health providers is based on the economic assumption. Every individual value income, higher income and more relaxed can increase their utility. So for each individual, they have the willingness to maximize their utility. So when the payment linking the different behavior outcome with the income level, the health providers will choose the behavior which can bring them the highest level of income. But more and more evidence have found that in addition to the financial income, the health providers also value other factors like the health standards of their patient and the professionalism. This Cochrane review aims to assess the impact of different payment methods for healthcare providers working in outpatient healthcare settings. Our methodology follows the guideline Cochrane and the guideline suggested by EPOC Center. Just mentioned several points which is special in this Cochrane review in the methodology part. The first one is we only targeting the included the payment targeting individual health providers. Some studies they use the word payment to health workers or health professionals, but when we analyze the content in detail, we found that their target are the payment target are group level or team level. We didn't include them. The second special part is we categorize the outcome into 5 categories, which are the outcome related to service delivery, the outcome related to the patient outcome, the outcome related to the healthcare provider side, because the payment involved the change of the income level, and the health providers need to change their workload based on the payment method. So it must have the impact on their filling and workload. And we also include the outcome on the cost of delivery system and the adverse outcome. Another special point in the methodology is also the most difficult part of this Cochrane review is to categorize the comparisons. Because the payment methods are very complex, and even the different study use the same terms like the fee-for-service or capitation or pay-for-performance. Actually, the design are different in each study, so we spend a lot of time to discuss how to categorize all the studies with varied design into several categories. All other parts of the method follow Cochrane guideline. Here is the screen process of our Cochrane review. We finally included 27 studies. Here is the result of our Cochrane review. When we describe the participant of included study, we found that the names of the health professionals in outpatient settings are different in different settings. There are primary care physicians, mental health physicians, pharmacists, and other health workers. And also the outpatient service facility, their features and characteristics are also different in different settings. Usually there are two big categories. One is independently operated clinics. Another one is the outpatient department in the hospital. After the long-term discussion and category, we finally group all the included comparison into 4 categories, which are the first one is the pay for performance plus exceeding payment method compared with the exceeding payment. In this category, the pay for performance involved extra fund. The purchaser or insurer use extra fund and pay them through the pay for performance way to incentivize certain performance target. The second category is fee for service compared with exceeding payment method, and the exceeding payment is usually one kind of input-based payment, salary or capitation. It means that the providers can estimate the total amount of their income beforehand, compared with fee for service, which under which the total amount of payment can be determined by the services they provided finally. The third comparison is fee for service mixed with exceeding payment compared with exceeding payment. In this category, the fee for service are different. Can be differentiated into 2 groups. One is use extra fund to pay through fee for service way. Another group is adjusting exceeding funding level, use part of the exceeding fund to pay them through the fee for service way. The last comparison is enhanced fee for service compared with exceeding fee for service level. It's a change of the fee for service from the lower unit fee to a high unit fee with a purpose to incentivize certain service delivery. In the following part, I will introduce the findings on the effects of different comparison. For the first one, the comparison regarding extra pay for performance. The below table shows the effect of extra pay for performance incentive on the health service provision outcome. We found that the extra pay for performance incentives probably increase the number of the children with up-to-date immunization standards. but we are uncertain of the effect on the immunization rate for the elderly. Regarding the outcome on the numbers of detailed disease-related consultation services provided the pharmacist, we found that the P4P added to existing payment may slightly increase this kind of the detailed services. And also, we found that the P4P extra incentive may slightly improve providers prescribing the guideline-recommended antihypertensive medicine. The red table shows the outcomes on the patient outcome. We are uncertain if the effect of the pay-for-performance added to existing payment method can improve the blood pressure control for the patient because of the low certainty of evidence. But we found that for another outcome, health outcomes is a mixed one. Improve blood pressure control or appropriate response to patient with uncontrolled blood pressure. We found that the P4P extra incentives may improve the levels of this outcome. The green table shows the effect of P4P extra incentives on the provider outcome cost or adverse effect. We cannot get certain evidence on the cost outcome, but we found one evidence on one adverse effect is that when the P4P intervention ended, there was an important reduction in performance in the intervention group compared with the existing payment method. It's reminding the purchaser or the insurer that once the P4P intervention started, there is a risk in the reduction or the stops in the effect of the incentives after the intervention stopped. Here is the result on the effect of the comparison to fee-for-service compared with existing payment method. We cannot get certain evidence regarding this comparison. The first reason is most of the studies included in this comparison have the higher risk of the high risk of bias. Secondly, the studies included in this comparison have very serious problem of heterogeneity. We can see that the relative effects, synthesis relative effects, have a very broad range. It means that the heterogeneity of the study included. But we found one low level of evidence on one adverse effect is the physician who received the fee-for-service payment may see more well patient compared with physicians paid by salary, because the fee-for-service have a motivation to push the health providers to provide more services. So some services may be unnecessary, like the same more well patient. Regarding the effects on the effects of the comparison 3, fee-for-service mixed with existing payment method versus existing payment method, we found that the fee-for-service added to existing payment method may increase the quantity of health services provided, and the services included are women screening services or children receiving some dental treatment. But we cannot find the certain evidence on the effects of the extra fee-for-service on the patient outcome. It is about the satisfaction of the patient with the care. we cannot get the certain conclusion on other outcomes because of the very low certainty of evidence. The last result about the effect of enhanced fee-for-service. The blue table shows the effects on the health service delivery process. We found that the paying higher rate to healthcare providers probably increase the proportion of children whose immunization is up to date. But we cannot get certain evidence on the effect of enhanced fee-for-service on primary health care visit by children. For the patient outcome, provider outcome, cost, and adverse effect, we cannot get the certain evidence on this outcome because of very low level certainty of evidence. In summary, for the comparison 1, P4P plus exciting payment method compared with exciting payment method, the assumption is extra money to pay through P4P can incentivize certain behavior in delivering certain services. The evidence shows that P4P indeed probably improve provision of children immunization services, may slightly increase more detailed services provided by pharmacists, may slightly improve primary care physicians apply with hypertensive management guideline, but we cannot get certain evidence about of the actual P4P on patient outcome. So it means that the P4P can only works to change the behavior of providers, but we cannot get the evidence on that it can improve the health status of the patient side. We also found one adverse effect is the risk of more decrease in performance after the financial incentive ended. For the comparison 2, fee-for-service compared with capitation or salary, the assumption is that the outpatient-based payment through fee-for-service can motivate the provision more services compared with the input-based payment. But because of the higher risk bias and the heterogeneity of included studies, we cannot get the certain conclusion on this comparison. For the third comparison, fee-for-service mixed with exciting payment method compared with exciting payment method. The mechanism is also adding fee-for-service, adding some output-based payment can motivate certain behavior compared with the pure input-based payment. The evidence shows that fee-for-service mixed into exciting payment may increase quantity of health services compared with the pure input-based payment, but we cannot get certain evidence on other outcomes. The last one is enhanced fee-for-service compared with the normal rate of the fee-for-service. The assumption is also the higher financial incentives linked to the delivery of the services can motivate certain service provision. The evidence shows that enhanced fee-for-service probably increase the children immunization rate, but we are uncertain whether higher fee-for-service payment results in more primary care visits. We are uncertain on the effect of enhanced fee-for-service on the cost and other health outcomes. In the discussion part, we want to emphasize the several points. The first one is that none of the outcomes in this review were assessed as providing high certainty evidence, and only limited evidence with moderate certainty level of evidence. We also have some discussion points on the application of this evidence. The first one is most of the robust evidence provided in this review was on the effect of the payment intervention involving extra fund to provide incentives for healthcare providers. So it means that the purchaser or insurer need more money to these interventions. It risks the application of the review findings in the settings with limited resources or with the resources, all the resources have the problems of sustainability. And we also need to remind the purchaser or insurer that even we found that the P4P or enhanced fee-for-service can work in motivate the delivery of some services, but the effect of this payment still depend on the specific aspects of the design of this incentive program. For example, what kind of performance target they selected, or how frequently the providers were evaluated and paid. We propose the following implications for the practice. If the policymakers intend to incentivize outpatient healthcare providers to expand the coverage of some services, especially some preventive, essential, or public health services, they might consider implementing P4P or increase the unit pay rate of the fee-for-service. But when the policymaker identifies some services of low value are being over-provided, they may want to consider switching away from fee-for-service payment. The third point is that considering the sustainability of financial incentive program and the need for the additional funding, the payer may need to be both cautious in initiating these schemes and to consider if they can be sustained. Especially sustain the fund availability in the long term. Also considering the disadvantages of the financial incentives, the purchasers need, or the policymakers need to consider some other non-financial incentives. They are also alternatives for changing the behavior of healthcare providers. We propose the following suggestions for future study. We need more studies, evaluation studies from low and middle income countries. We need more study comparing or evaluate different design of the same payment method, but not just change from one kind of payment method to another kind of payment method. We need more study with theory-informed qualitative component that can deeply implore why particular payment interventions work or not, and under what circumstances. And we need more study evaluating the adverse effect or unintended consequences. We need study with more detailed information on health system context in the study settings or detailed descriptions of payment interventions used, which will be helpful for us to explain the effectiveness of the payment method and propose the suggestions for the policymakers to design their payment method. Thank you very much.